We have now started covering the basics, and let's realize that what we will be talking about is our day-to-day work in our outpatient or in our inpatient. We need to know that examination of the back starts with examination of the gait, and commonly you will find that if the patient is in pain, especially back pain, facet related pain, disc related back pain, then they will have spasm of the back. If the patient has sciatic pain, they may be limping. If the patient has sciatic pain and in addition weakness commonly of the hip abductors, which is supplied by L5, then they would probably present with a limp which will be distinct, and you could make out it is not antalgic, but it is because of weakness of the hip abductors. It would be more like a lurch, as we call it. If the patient has claudication, then you will find that the gait will be quite okay to start with, but as the patient goes on, then you will find that the patient is unable to walk properly, and then they start limping after a certain distance, and this is what they will talk about. We need to see the spine contours, and we know that in degenerative lumbar spine, normally there may be a hyperlordosis in patients who may have listhesis, but otherwise there is much of a straightening of the spine, and there is a restriction of extension of the spine. Where we come to the range of motion of the spine, and we know that we need to examine the patient for flexion, which commonly would be limited in patients with sciatic pain because of the disc herniation, giving rise to dural irritation from the front. Extension would be limited, especially when the patient has a facet-related problem. It would be painful, and we will find that the rhythm in these movements will be lost depending on the location of the cause and the severity of the cause. We need to elicit the reflexes, remembering that in an adult aged above 60, if the ankle reflex is present, then we must rule out a upper motor neuron cause, commonly a cervical myelopathy. Slowing of the reflexes or lethargic reflexes do not really make much difference to our decision making, except adding a shade of seriousness to what we think about. Then we have to go for root irritation signs, and in this we must remember that inflammation is the basis of pain, and unless there is a priming of the nerves by inflammation, there cannot be pain. That is number one. Number two, when the nerve is inflamed, there is an upregulation of sodium channels in the nerve, and the nerve becomes extremely tender to touch. I already described in my sign two spots around the ankle where the deep peroneal nerve and the sural nerve are extremely tender to touch, indicating L5 and S1 affection commonly respectively. Then if the root mobility is affected, we will find that the straight leg raising would be affected and would be restricted. Of course, if the problem is much more severe, then the patient may also land up with neuro deficit, which could be sensory or could be motor, depending on the cause, intensity and severity. We also need to remember that many times these conditions are mimicked by conditions from the hip. For example, if the patient has avascular necrosis of the femoral head, the patient may have groin pain, but in these patients it could be bilateral. The pain could radiate up to the knee, but commonly on the medial aspect of the knee rather than on the trochanteric side or on the side of the thigh. The other thing which is important is in case of hip affection, the rotation of the hip and abduction inflection commonly are affected, and in Indian scenario the patient will not be able to sit with crossed legs. So the patient would find it very difficult to sit in that position. Otherwise, the patient may be fairly normal in other aspects. We also have to remember that the pulses have to be elicited, especially the tibialis posterior or the posterior tibial artery, and of course the dorsalis pedis, which will tell us about the state of circulation, the state of atherosclerosis in elderly diabetics, and whether we are dealing with a systemic problem more than the local spine problem. This also helps us in distinguishing between the vascular cause of claudication and the neurogenic cause of claudication, which commonly would be presenting to us rather than the physicians or the vascular surgeons. There has been a big talk of non-organic signs, mainly mentioned by Waddell, but I would like to differ from that. I would say that we need to keep those in mind, but they come last. They are not the first thing to be elicited, and we need not give extra or excessive significance to these non-organic signs which have been described by Waddell, which indicate to us that the cause is more functional rather than organic. In a society like ours, where people earn and spend on their own, and as yet a majority of the part of the society is not covered by insurance, the chance of somebody malingering is little less as compared to a prosperous society or a society covered with social welfare benefits, where it is to the advantage of the patient to mimic certain things without actually suffering from that. Then we concentrate on the examination, and we see in standing position, where the patient is standing with the back towards you or the face towards you, you check the gait. In that we check the toe walking, that is the heel is raised and there is a plantar flexion of the foot, where the S1 is tested for motor power, or the heel walking, where the patient walks on the heel. Sometimes it may be difficult because of pain in the heel associated, and heel walking is mainly to check the dorsiflexors of the foot, namely the tiband and the other dorsiflexors of the foot. Then when the patient is with his back towards us, we look for deformity in the back or tenderness anywhere in the back by palpating the midline, by palpating the spinous processes, and maybe gently tapping those spinous processes with our fingers or with our hammer, which we use to elicit the reflexes, deep tendon reflexes. Then we can look at the skin, where rarely you may find patients who may be having herpes, where they may have those classic eruptions which may be along the course of the nerve, where the dorsal root ganglion is infested with the herpes virus, and the virus is showing these eruptions along the path of the nerve. Then we ask the patient to flex, extend, and rotate. In case of flexion, we need to see how the skin is stretching over the spinous processes, whether the flexion is limited, especially by looking at inability of the patient to touch his or her toes while bending in the front. In extension, we need to find out how much is the extension, and not allowing the patient to extend in the neck and asking the patient to extend in the back. When the patient extends in the back, we find that sometimes the pain in the back may peripheralize in the lower limb, or the pain in the leg will centralize in the back, giving us an idea about the integrity of the annulus and the likelihood that if the pain is centralizing, it may settle with a natural resolution of inflammation and healing of the annulus. In case of claudication, we have found that if the cause is anterior to the dural sac, then the extension commonly is not affected, and in case where the cause is probably posterior or posterolateral, Closer to the facet joint, we have found that extension is limited because the foramen becomes smaller with extension, and the extension also gives more radiation to the back of the thigh in case of S1 affection, and to the leg, calf, and the side of the leg by L5 affection. Now, we need to also see the rotations, especially in the dorsal involvement, and find out if the patient is able to rotate properly or not. Then we see the patient in lying down position, where the patient is lying supine. We check the sensations right from the umbilicus down, and we also check the power, commonly standing at the foot end of the bed and checking the extension of the big toe, the extension of the foot, and the plantar flexion of the foot in general, where we will be checking the L5 and S1. Then we check the reflexes, mainly the knee and the ankle, and as we mentioned before, if the ankle reflex is preserved in an elderly patient, we must rule out a upper motor neuron type of involvement. A straight leg raising is then elicited as to find out if the nerve mobility is affected. It is also checked on the other side, where a cross SLR positive, the classic sign of a disc herniation, can be elicited. Distal pulsations are seen, and we also do a palpation of the abdomen to rule out any gross lumps or any gross tenderness in the abdomen, where there may be pulsatile SOLs and tenderness indicative of colitis or any other infective problem in the belly. Now, after this examination in lying in supine, we ask the patient to lie prone, and we check the tenderness on the spinous processes or paraspinal area in case of facet affections, or we ask the patient where he experiences the pain. We palpate along the site of pain to rule out local lumps and bumps. We also do the Mackenzie's test, which, as we know, is extension of the upper spine without actually raising the legs. And we have found out that if the annulus is good, which can heal and which can recover with natural resolution of inflammation, then there is a centralization of the pain. If the pain peripheralizes, then we need to keep a watch on the progress of this pain. We recheck the ankle jerks in prone position. It may be a little easy to elicit them if we allow the legs to be out of the bed. And we also do a femoral stretch sign, especially when there could be a suspicion of upper lumbar disc herniation, whereas we know that instead of the sciatic nerve, the femoral nerve is restricted in its mobility, and on extension of the hip with the knee flexed, without the knee flexed, we will have painful elicitation of the femoral stretch. Then we will have some important queries. This is mainly to make it very easy for us to understand that we are not dealing with anything very serious. And the queries are, is the patient having any red flags? That is, in case of trauma infection tumors, in case of genitourinary, and in case of gastrointestinal diseases and Cauda-Equina syndrome, we either have a gross neurodeficit or we have such a severe pain that the patient is tossing in bed or is unable to sleep, or the pain is there all the time, even at night. We have seen that in case of neuralgia, many times the pain is present at night, but it is mainly because of the cold at night rather than seriousness related to the red flags. Then we ask the patient where is the pain coming from, and are there any associated issues about the effect. That is, the CNS is affected, there is instability, there is a fear, depression, and there is a problem with coping with these issues, especially by the nature of the patient's narration. Our concentration will be on the basic question, or a fundamental question as we call it, where is the pain coming from? And we need to look at centralization of the pain, what we have described, that is asking the patient to be in prone and extend the upper part of the spine and see whether the pain comes to the center, comes to the midline, comes to the lumbosacral junction. We need to find out if the pain is arising locally from the facet or the sacroiliac joint. We need to check the nerve mobility, whether it is moderate or severe. And then of course, we check the sign which I have described by palpating the nerves, the sural nerve and the deep peroneal nerve, as to make out whether we are dealing with inflammation of the nerve root, which may be the effect of nucleus pulposus coming out. Again, we would highlight these 6 questions, which are very simple to remember in our basic examination. Is the pain which the patient is talking along the sciatic nerve, that is the location of the pain? What is the intensity and time when it is felt? What is the quality of pain and relation to sitting, standing, walking and lying down? And what are the non-painful sensations, that is paresthesias, burning, etc., etc. Now, in relation to the posture or position of the body, we need to know that in case of disc herniation, sitting is very painful. In case of claudication, standing and walking is normally the one which creates issues. And if the pain is more in lying down, even in lying down, then it's normally a red flag. If the pain is along the sciatic distribution, then if it is sciatica, which root is affected? That is L5 or S1, which is commonest affection. If it is the disc, then which disc is affected? Then we think of invasive and non-invasive imaging, that is the MRI scan commonly nowadays, and a discogram if you feel it is absolutely mandatory to know the morphometric changes in the disc and the correlation of these changes with the pain elicitation. And then we ask the question again, is the pain inflammatory or mechanical? Is it resolving? And why is it not resolving, or why is it persisting? And has it become neuropathic where the nerve itself is affected? Then looking at the MRI, we make some guess about the status of the nucleus, the annulus and the nerve root, which can also be done based on our clinical analysis. If it is claudication, that the patient says, I am unable to walk beyond a certain distance, or I have to limp after walking a certain distance, then we need to ask the question, is it a vascular cause or a neurogenic cause? Now, all of us know this, that there are certain core areas which are supplied by respective roots. And if we look at the anterolateral view of the lower extremity, the black thick line represents the sharp radiating pain which has dermatomal distribution. The sharp radiating pain in S1 is indicated by interrupted lines here in this picture on the back of the thigh. It tends to be in the center of the posterior thigh and the calf, and the diffuse gray area represent poorly localized dull ache. And the circles where the pain may be concentrated, that is in case of S1, it may be the calf and the heel. In case of L5, the big toe. In case of L4, the tibial tuberosity or the upper part of the shin. And in case of L3, it could be the lower part of the anterior thigh or peripatellar or inside of the patellar area. The area covered by small dots is the location of paresthesias and sensory impairment, and you will find that in case of S1 it is the lateral border of the foot, in case of L5 it is the front of the leg and the first web space, in case of L4 it is the shin area, in case of L3 it is the lower part of the anterior thigh. And picture A is of S1 radiculopathy, B is L5 radiculopathy, C is L4 radiculopathy, and L3 is the D picture is L3 radiculopathy. So this should be extremely clear to us what we are dealing with. Then of course we ask the patient about the severity of the pain. The first was location, the second is severity, and as we know 0 is no pain and 10 is overwhelming pain, where the patient feels like crying, and in Western literature they say it is so severe that you feel like committing suicide. I mean, it's extremely severe. Then of course we do the Mackenzie's test, and it differentiates the discogenic from non-discogenic pain, and it tells us about a competent and incompetent annulus in symptomatic disc, and it is supposed to be superior to the MRI in assessment. Now, this has been reported in Spine 1997 by Donaldson, who is the disciple of Robin Mackenzie, who first described this test for our understanding. Now, we know now that this test is very simple and tells us a great lot about the annulus and how this test helps us in differentiating the patient, whether he needs surgery and intervention or it is going to settle with natural resolution of inflammation. Here we have to remember that our primary aim of treatment is to find out whether the pain is recoverable by natural means, and if yes, is it only chemical or mechanical, so as to keep a watch on those factors related to the pain. In case of Mackenzie's test, we are not supposed to raise the neck, we are supposed to raise the chest and not supposed to raise the legs also. Now, in case of symptomatic disc, as has been shown in this picture on the left, the patient may have pain going down the leg, but when the patient does extension of the back or repeated extension commonly, then the pain centralizes, as is shown from the images from left towards the right, and the pain may peripheralize if the pain is arising out of a trapped nuclear fragment sitting in the annular tear and not allowing the nerve to go away from that area and continuously irritate that nerve. So in that case, we will say that the pain is peripheralizing. Now, I have already talked about this, and I would invite you to have a look at this paper which I have published as the basis of stitchless spine surgery under local anesthesia, and it goes as my matrix, the Gorez matrix. In simple words, it's a collection of 6 symptom groups based on clinical examination. And what has happened is, unnecessarily in the past, we were taught and we were told that the symptoms are infinite, and we were lost in the descriptions, we were lost in the descriptors, and we were told that in majority of the patients we cannot diagnose these patients. Now that is not true. We can definitely diagnose the patients, and we can make a meaningful contribution to the treatment of the patients. Now, we will come down to the basic question as we mentioned. Where is the pain coming from? The first thing which we need to understand is, in a degenerative spine, there is a structural failure. Here, as you can see, the failure is in the form of an annular tear, where the annulus is torn and it is leaking, where it may involve the nerves, the sympathetic chain, and the peripheral or the spinal nerve. There are 4 common pain generators based on the study by Stephen Kuslich, where he has published in the form of Tissue Origin of Back Pain and Sciatica. It could be the posterior annulus. If it is affected in the center, it commonly manifests as back pain. It could be the posterolateral annulus and the nerve, where it may manifest as sciatic pain. It could be the front of the facet joint, where there could be a hypertrophy of the tissue, giving rise to increase in sciatic pain and or claudication. And it could be the facet joint itself, which is a synovial joint and can be affected by all the arthritic conditions of the joints. Now, when we look at these 4 targets, we must remember that inflammation has to be present. Otherwise, only the changes do not give any issue. In case of back pain, then what we do is essentially we do the Mackenzie's test. Now, in case of back pain, we need to know on the right side that the pain is on the sides, which commonly comes from the facet, and when we do an extension of the back, the pain increases. It also increases with rotation of the back, and commonly we offer medical treatment or an injection to the facet or a facet denervation, which we will be talking in detail later on. Then the pain could be central or in the axial skeleton, and it could be vertical, commonly associated with L4-5, or horizontal like a belt along the belt area of the back, which is commonly with L5-S1 disc related pain. This pain may centralize, that is on extension, the pain may come to the center and localize to a spot, in which case we follow a medical treatment or at the most an injection inside the disc to take care of the inflammation. If the pain is not centralizing, then we do a discogram and or a MRI scan nowadays as a basic investigation, which is non-invasive, and if there is a fragment, we remove the fragment. If there is no fragment, then we think and we probably would consider giving a block to the patient so as to stop the pain. As we have described, the back pain coming from 5-1 is commonly horizontal like this. The back pain coming from facet is generally paraspinal, well localized, increases with extension and rotation, and the back pain coming from 4-5 with a central annular tear is commonly seen to be vertical. Now quickly we will touch this issue of discography, because we have found that there are a lot of misconceptions about discography. Now this is a patient who is 22-year-old male and has a scan which looks fairly normal, as you can see here. But when we do a discogram, you will find there is an annular tear here in the annulus. There is a leak here which can be seen with a post-discogram CT, and this patient had an acute onset low back pain because of annular tear at L4-5. Now this information will not be available to us unless we do a discogram and demonstrate this tear. So doing a discography definitely helps, but clinically, if you are able to make out these things, then over a period of time, because you see many more patients, you will be able to diagnose them clinically and on MRI. Now this is another patient who is a male aged 32 who came with acute onset low back pain, and the pain was more horizontal than vertical, and here the scan looks more or less normal, but a discogram shows an annular tear at 5-1, which with a post-discogram CT shows the dye which is coming here, which is more in the center of the disc and giving rise to irritation of the tissue anterior to the dura, and at the edge of the PLL will give rise to pain. Here there is a piece of nucleus which is trapped in the annulus. It is not coming out and having a herniation. It is not going back. And these are the patients where the patient does an extension of the back. The pain may not centralize because there is a piece of nucleus sitting there. Then we go to the leg pain. In case of leg pain, the main thing which we need to know is my sign. The leg pain could be in the back of the leg or the heel, which is commonly associated with S1, or the lateral aspect of the knee and the leg, which is commonly seen with L5, as we have already mentioned. This pain may centralize on Mackenzie's test, and a distal block will help. That is, an injection at the spots which I am describing very soon will relieve the pain. This is described in my publication with my colleague, Sciatica Detection and Confirmation by New Method, which you can check on the internet, and you will find it in this International Journal of Spine Surgery. When the patient has a centralization of the back pain or the leg pain and a distal injection at the ankle helps, then we commonly conserve the patient. If the pain is not centralizing, an injection at the ankle is not helping, the SLR is positive, there is a neurodeficit, then in the past we used to do a discogram as has been described, or we can always go in for an MRI scan and demonstrate the fragment which is coming out and giving the problem, where we remove the fragment. If there is no fragment, then we again go back and think of giving a medical treatment to the patient. Now it is very simple and based on my sign, and we must remember that the first manifestation of pain coming from L5 is almost always knee pain, which is commonly lateral to the knee, inferolateral to the knee. And you would be surprised to know that the patients who talk of pain in the knee or pain around the patella even at a younger age may be harboring a cause related to L5. The pain in the heel is the first manifestation of pain related to S1, and this is seen commonly on the lateral aspect of the heel. It could also be seen below the heel. The older description of growth of bone on the heel bone is absolutely unscientific. There is no condition like plantar fasciitis which commonly would not present like the neuralgic pain. We need to know these three spots very well as per my sign. The first one is this, which is the deep peroneal nerve, which lies below the extensor digitorum brevis muscle, and this is indicative of involvement of the deep peroneal nerve in inflammation. This is a picture of the lateral aspect of the calcaneus showing the sural nerve, which is a very important nerve, otherwise also can be felt very easily against the bone, which is indicative of affection of the S1 radical. Now, in addition to the deep peroneal nerve, sometimes we also find that the posterior tibial nerve on the medial aspect of the ankle is inflamed and is involved in the inflammatory process, indicative of L5 nerve affection. This is again showing the spot. You feel the fibula come anterior to the fibula, and you will find there is always a vein here, and this is the area where you feel the nerve against the calcaneus, and you will find it's extremely painful. There's one more very simple, subtle finding in these patients, and that is if they have a S1 affection associated with it, then because of the affection of the venous circulation, there could be a fullness behind the ankle. This is a very important subtle sign where the S1 also may be affected. So to summarize, in case of sural nerve affection, you feel the nerve on the lateral border of the calcaneus, on the upper border of the calcaneus commonly, but this is the course of the nerve. This commonly is midway between the fibula and the tendo-achilles on the upper border of the calcaneus, and the deep peroneal nerve, which is just in front of the fibula on the roof of the sinus tarsi, just behind and above the extensor digitorum brevis muscle. Now, the next thing what we do in these patients is we know that these two spots are painful. These spots indicate the nerve affection with inflammation. Then commonly we used to give a selective nerve root block to L5 in the foramen. Now here what we could do is we could also give a distal block, that is we can inject lignocaine here in the sinus tarsi or on the lateral wall of calcaneus, and it has the same effect. Now this has to be done to appreciate the effect of this injection. And I can tell you that all those patients who have inflammatory pain get instant relief. The next question which you probably are going to ask me is how long will the relief last? The relief will last for minimum few hours, more than the action of local anesthetic, and it may last for a long time. The second thing is this is a procedure which can be done in the outpatient. It doesn't need any technology, and it can be done very simply by injecting 2% lignocaine 3 cc without adrenaline in this area to relieve the pain. Now, when we are examining our patients, we need to also know that we will be seeing patients who will be having claudication. In case of claudication, what we do is very simple. We ask the patient to go through this questionnaire, which is to be filled by the patient. This is a self-administered questionnaire, and we ask them to give the answers yes or no. It commonly takes less than about a minute to know. And you know that if all 10 are yes, it is severe. If 6 are yes, it is moderate. If 2 are yes, it is mild form of claudication. Now this gradation doesn't really help, but if it is severe, we need to think of intervention. In addition to this, what we have to do is to do a ultrasound examination for post-void residue of urine, which will take us to the point where we will be emphatically able to tell the patient that the detrusor muscle is weak and the retention of the urine is already there, indicative of a neurogenic bladder. And as we always say, if we are able to detect it even before we intervene, it is much better rather than landing with a retention of urine after you have intervened. Now we also do X-rays either in standing, or we do X-rays in the flexion extension to find out the dynamics of the situation. And commonly it is described that if there is a translation of more than 6 millimeters, then it is significant. We can also do a loaded or a dynamic MRI, and as we already mentioned, the post-void residue, if it is more than 60 ml in a female or 100 ml in a male, it is very significant, and it must be done in all the patients who come to us who are above the age of 65. We need to keep in mind that we also deal with instabilities which can give rise to claudication, where here you can see a listhesis or a lysis giving listhesis, and here you see the open facet sign, where in case of listhesis the facet is supposed to contain fluid, which definitely indicates a micro instability. Now this clinical examination of the patient has to be followed by our reading and updating our concepts, and this is our publication which has been published in Surgical Technology International, and we are talking about in vivo endoscopic visualization of the pathoanatomy in symptomatic degenerative conditions. So what we are trying to convey to you is all these symptoms can be very well correlated with the pathoanatomy under local anesthesia by putting a scope when the patient is awake and aware. And I have published my technique, my inside-out transforaminal technique for lumbar endoscopy in association with my teacher, Dr. Anthony Young. We have also published on sciatica detection and confirmation by the new method. We have also published on endoscopically guided foraminal and dorsal rhizotomy for chronic back pain because of the facet, and of course endoscopic foraminal decompression for the failed back surgery. So what we are saying is we need to know what are the differences in the traditional surgery and the surgery done by my system. Traditional surgery, the decision making is commonly based on images. It is done under general anesthesia. There is bleeding, there are cuts, hospital stage, there are stitches. It is expensive and morbid, and there are dreaded complications. And return to work may take a few months and sometimes even longer. My surgery, my system is based on precise pain diagnosis done under local anesthesia, and since we know that the cause of the pain is only sub-centimeter, the surgery is stitchless, there are no blood transfusions, it can be daycare surgery, less expensive, less morbid, almost no dreaded complications, and there is a very early return to work. So to summarize, I would say that precision diagnosis for pain and not only choosing a patient for surgery is essential. What I mean is, traditionally we have been only choosing patients for surgery. It should be also precision diagnosis of pain. It is based on patient narration and visualization of etiopathology. Then we target the symptoms, the area under local anesthesia. We are able to cover all disc herniations and repair the annulus at the end of the surgery, and we can also solve the stenosis by the same surgery by extended application of my system. Now we have limited select use of implants and our surgery is not image guided. So to sum up, Gore's system is effective in treating lumbar disc related problems. Thank you.